Good afternoon, my dear teachers and my dear colleagues. After listening to an excellent lecture on obstructive sleep apnea, let me give a chance to expression your knowledge on the management of asthma in 2020. At the same time, I would like to thank the college for giving us this opportunity to present our presentation. So my scope will be based on the definition and the diagnosis of asthma. And since we are facing a pandemic of COVID-19, how to manage asthma in the background of pandemic. At the same time, I'll be briefing few words on asthma phenotypes and the changes that has taken place recently with regards to the long-term management and short-term management or the acute management with regards to asthma. By definition, asthma is a heterogeneous disease usually characterized by chronic airway inflammation, and it is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, cough, which may vary over time and intensity together with variable expiratory airflow limitation. On the other hand, airflow limitation may later become persistent. That is why you will not see the typical bronchodilator response when you do lung function when the patients are having advanced asthma state. Now, in order to diagnose the asthma, this is based on basically characteristic symptom patterns, and also on the other hand, you are objectively measuring the airflow variability by doing different tests. And the most important thing is you should document the bronchodilator reversibility and other testings that you are doing when you are diagnosing asthma, because this will be important if the patient is not responding to a treatment and if you are going to assess or you have to reconsider the treatment for a second time. So this is mandatory. On the other hand, you should test before treating, because your treatment will affect the test. So almost all the time you should test whenever possible before treating. And documentation for documenting the evidence for the diagnosis of asthma before starting control treatment is also very important, which is again important when you are managing and the patient is not responding. There are certain features which may help you or which may increase the probability of diagnosing asthma, and also there are certain features which will turn away from asthma. So if the patient is having certain symptoms like experiencing more than one symptom, or if the patient is having diurnal variability, or if the patient is having symptoms varying during the daytime and during night time, and also if you can figure out any triggering factors which can exacerbate asthma, so these features will be supporting your diagnosis. On the other hand, if the patient is having isolated cough apart from cough variant asthma, and if the patient is having very chronic production of sputum apart from the cough, and if the shortness of breath is associated with dizziness, lightheadedness, or peripheral tingling, chest pain as the main symptom, and also noise inspiration with exercise-induced dyspnea, so these features will not telling with your diagnosis. Now this is a chart which will show which shows the subjective and objective assessment of the patient. So apart from the history part, if you are assessing the patients, basically in our setup we are using peak expiratory flow rate variability and also the lung function. So if someone is having peak expiratory flow rate varying more than 10% when you are measuring the values, that is suggestive of asthma. On the other hand, if you are checking for FEV1 and if you are looking for the bronchodilator response, if it is more than 12% or if it is more than 200 ml after bronchodilator therapy, that is also supportive of asthma. Now, recently there has been a good interest on the role of fractional excretion of nitric oxide, so I will be briefing few words. Now, the important is the fractional excretion of nitric oxide is associated with blood and sputum eosinophil levels. On the other hand, this is seen in patients who are in type 2 inflammation. So I will be discussing on asthma phenotypes, which will be highlighted this. And also, if the patient is having neutrophilic asthma, that is, if the patient is not having type 2 inflammation, the FeNO will not be elevated. And also, in smokers, FeNO will be low. Apart from all these things, FeNO will be elevated in conditions other than asthma, like eosinophilic bronchitis, allergic rhinitis, atopy, and eczema. So based on all these things, it is recommended. Now this should not be established as a rule in or rule out test for asthma. On the other hand, this can be used to monitor the response if you are dealing with a patient who is having asthma in an advanced state. Since we are facing a COVID pandemic, there are certain changes that has been administered or advised when you are managing patients. Now, there was this dilemma. If the patient is on inhaled corticosteroids or if the patient is taking oral steroids for their control, whether to continue the drugs or whether to stop the drugs. So this was a dilemma. So ultimately, considering all these risks and benefits, it has been recommended you should continue inhaled corticosteroids and oral steroids if the patient is on these drugs. The reason is if you withdraw these drugs at once, there will be life-threatening exacerbations which is associated with adverse outcomes. And this rule is applied for biologics as well. And almost all the patients should be given written as an action plan, what to do, when to come, what are the symptoms, all these things has to be given and written and given to the patient. The basic therapeutic modality, nebulization, should be avoided as much as possible. As you all know, nebulizer is an aerosol generating procedure which may increase the chance of transmitting viral particles. So wherever possible, you can use MVI with a spacer which is equally effective. And there are instances where the people share inhaler devices, which should not be done. And currently, there are autoclavable spacers, and when these things are available, you can administer autoclavable spacers for the patients. And if you are working in a if you are suspecting, or if there is a confirmed patient with COVID-19, you should not subject that patient to spirometry. On the other hand, if you are working in a patient in a center where there is community spread is seen, then you can postpone spirometry unless that is really indicated. Despite all these measures, there will be a group of patients who will deteriorate, which needs advanced treatment, and also the patient may be requiring intensive treatment. So in those instances, all the infection control measures has to be taken, and patient should be separated. And in that case, you can provide the patient with oxygen therapy, sputum induction, manual ventilation, navio intubation, taking almost all the safety. This asthma phenotypes has been recently described because this is important when you are managing patients who are poorly responding to the treatment. Now, this is a recognizable cluster of demographic, clinical, or pathological characteristics, which is called asthma phenotypes. And there are this is clinically used because when the patient is having severe asthma, phenotype guided management is available, which we'll be discussing in a while. However, there is no strong relationship has been found between specific pathological features, clinical patterns, and treatment response. Few examples for asthma phenotypes are allergic asthma, non-allergic asthma, adult onset asthma. Earlier it was mentioned as eosinophilic and neutrophilic asthma. So these are the examples. Now, whenever you are managing a patient, there should be a set of goals. So these goals will be patient specific or the clinician specific. If these goals are patient specific, there will be personal goals which will be totally different from the clinician's aspect. As an example, imagine there is a patient with a football player who is having asthma. His basic target will be going back to his normal sports life with minimum symptoms, whereupon the clinicians will be having different aspects. So the personal goals are very much important. On the other hand, the clinicians also should have certain goals, that is maintaining normal activity level. So we should allow the patient to live a near normal life, and we have to achieve symptom control. On the other hand, while treating, we have to minimize the risk of asthma related deaths, exacerbations, persistent airflow limitations, and drug related side effects. This can be achieved by adhering into asthma action plan, which consists of 3 steps, that is assessing, making certain adjustments. Once you adjust changes, you have to review the response and see what is going on. When you are assessing the patients, first you have to confirm the diagnosis if it is needed, or if it is not clear cut, you have to assess the symptom control and modifiable risk factors. You have to check for the comorbidities, inhaler technique adherence, and also patient preferences and patient related goals. So adjusting needs modifiable risk factors, non-pharmaceutical strategies, asthma medications, education, and skills training, that is mainly with regards to inhaler techniques. So once all these things are done, you have to review the response, whether the patient has responded or not. We are moving towards the changes that has taken place recently with regards to the management of long-term asthma. If I want to highlight a single slide from this presentation, I think this is the most important slide, because if you are thinking of long-term control of asthma, there is no longer recommendation of treatment of asthma in adults and adolescents by using short-acting beta agonists alone. We will be discussing in a while why is that. Apart from on top of that, the recommendation is all adolescents and adults should receive ICS containing controller treatment from the beginning. This may be a regular daily treatment, or maybe a combination of ICS or inhaled corticosteroids plus formoterol combination. This is the landmark change that has been made for the last few years. So why is this new change? In mild asthma, as needed it has been shown, we will be seeing the evidence. In mild asthma, as needed low dose ICS formoterol reduces serious exacerbations compared to SABA alone. So this is proven. On the other hand, this combination is equally effective to daily low dose ICS for severe exacerbation. Imagine someone is asked to take regular ICS containing inhalers. On the other hand, someone is asked to get the inhalers when needed. So obviously, the second option will be a better one with regards to compliance. So he will go for that. So rather than taking regular inhaled corticosteroids, we can ask the patient to go for a combination SOS. On the other hand, why SARB alone is not recommended? So this is twofold. One is this is associated with adverse effect. On the other hand, this is associated with adverse outcome, that is even the mortality. It has been shown in 2000 by Hancock and others. The regular or frequent use of SARB is associated with beta receptor downregulation, decreased bronchoprotection, rebound hyperresponsiveness, decreased bronchodilator response. In addition, in 2000, it has been shown there is an increased allergic response and increased eosinophilic airway inflammation, which will lead to irreversible changes by using SARB alone for a long-term period. As well, higher use of SARB is associated with adverse clinical outcomes. In 2012, Stanford showed if someone is using more than 3 canisters per year, that is roughly about 2 puffs per day, is associated with higher risk of emergency department presentation. We are talking about SARB alone treatment. And if someone is dispensing more than 1 canister per month, that is associated with higher risk of death. Despite all these things, the recommendation of ICS formoterol combination has been made. So this is the evidence. Now, in 2018, this is a double-blind large trial recruiting 3,600 patients, which shows the combination of budesonide formoterol in mild asthma has a better outcome than SARB alone treatment. It has been supported by 2 trials which have been published last year. One is the Novel START trial. However, both these trials are open label trials. In Novel START trials, it has been shown the sample size is 668. It has shown budesonide formoterol used as needed was superior to albuterol used as needed for the prevention of asthma exacerbation. On the other hand, the practical trial, which was published in Lancet in 2019, again showed budesonide formoterol used as needed for symptom relief was more effective at preventing severe exacerbation than maintenance low dose budesonide plus as needed therapeutically. So this is with regards to formoterol combinations. However, both these trials are open label trials. Now, someone can think now, okay, you ask us to give formoterol ICS even for as a controller. So what is the higher dose? So you can't use as much you need. The higher dose, if the patient is using a budesonide formoterol combination, the maximum dose that you can use is 72 micrograms of formoterol per day. Usually what we have is the inhalers that we have is 6 mics. Each puff has 6 micrograms usually, so you can go up to 12 puffs per day if you are concentrating on formoterol. On the other hand, if you are using the combination of beclomethasone and formoterol, the higher limit is 48 micrograms of formoterol, that is about 8 puffs. This is the chart which shows, I extracted this from GINA guidelines, the chart which shows the stepwise management of the patients who are having poorly controlled asthma. Look, at step 1, as needed low dose ICS formoterol is recommended. On the other hand, if someone is using SARB alone treatment, whenever SARB is taken, that has to be combined with steroid containing inhaler. So SARB alone treatment is not recommended anymore, and the stepwise management has been there. On the other hand, step 5 is modified a lot. We will be discussing it in a while. Apart from that, long-term management by using aminophylline is not mentioned, and aminophylline has been kicked off from the management. If someone is having properly controlled asthma, and if you consider that you can go down with the treatment, there are certain measures that you should again take. Now, before considering stepping down, the patient's asthma control should be maintained for at least more than 3 months. And patient should be provided with a written asthma action plan, and that patient has to be monitored closely. And if you are considering stepping down, you should not completely withdraw ICS component unless indicated, because it may cause serious exacerbation. And all the patients should provide inhaler skills training, and you have to ask the patient to adhere to the treatment even the patients are having minimum symptoms, and patients should be provided training asthma self-management as well. Apart from that, if the patients are having any risk factors, you should provide regular daily ICS containing medications, identify and address modifiable risk factors, consider non-pharmacological measures like smoking cessations, etc. And whenever you are prescribing drugs, you should check for the local eligibility and the payer criteria for the patient. This chart again shows how to titrate drugs based on the severity of the symptoms. So if the patients are having minimum symptoms like less than twice a month, you can start it as needed low dose ICS formoterol. However, if the patients are in poor control, you have to step up the treatment. Now, the recommendation of ICS has to be started from the beginning is supported by number of trials. So, ICS containing control treatment should be started as soon as the diagnosis of asthma is made. The large trial is the STAR trial, which shows early initiation of low-dose ICS, which is associated with greater improvement of lung functions than symptoms lasting for years. There's another trial which shows early treatment of asthma with an inhaled steroid may prevent patients from developing chronic airway obstruction. The third trial shows if the patient needs treated at a later stage to achieve the proper control, the patient has to be put on a higher dose of steroid. This chart is added to show the amount of steroids that can be used based on the low, medium and high component level of steroid components that you can use when you are managing with patients. So what we are mainly concentrating on beta-beclomethasone and fluticasone. Last year at ERS, mometasone containing inhalers has been put into trials and they have a positive response. So very soon mometasone plus formoterol combination will be available in Sri Lanka. What is new for step 5 management? As we discussed, when the patient is reaching the level 5 or the step 5 with poorly controlled asthma, there are newer recommendations that have been made by the GINA. So first thing is you can add tiotropium in addition to high dose steroids plus LABA. However, the dose is a bit different from the inhaler which is available here, that is 5 micrograms. In addition, you can add azithromycin 3 times per week. However, before starting, you should exclude arrhythmia, the risk of getting prolonged QT prolongation, and you should exclude the chance of having atypical mycobacteria. So you should do cultures before starting azithromycin. And if the patient is now, we are mainly treated based on the phenotype. So if someone is having allergic asthma, anti-IgE treatment can be started with omalizumab. And if the patient is having severe eosinophilic asthma, that is treated with anti-IL-5 treatment. And despite all these measures, and if these drugs are not available and if the patient is having poorly controlled asthma, you can start the patient on oral steroids. However, as much as possible, better to keep the patient on a dose less than 7.5 of prednisolone equivalent. Apart from that, there are new trials coming with regards to bronchial thermoplasty, which is associated with better long-term control, although it is associated with short-term exacerbation. Sputum-guided treatment is recommended, where you will be monitoring sputum eosinophil levels and you will be titrating drugs to achieve the proper sputum eosinophil levels. And despite that, the other interleukin-4 receptor antagonists are also can be used. However, the use of these drugs in Sri Lanka is limited. We have a couple of patients who are waiting in the list to get the drugs to start on them. Despite all these things, there are modifiable risk factors that you should take measures. So these are the basic modifiable risk factors. I would like to highlight 2 points in these modifiable risk factors. One is with regard to pneumococcal infection, that is pneumococcal vaccine. Pneumococcal vaccine does not have sufficient data to recommend. So despite in others, and although we recommend pneumococcal vaccination in other conditions, we don't have sufficient data to recommend on regular pneumococcal vaccine. However, you can try. In addition, if someone is having allergen exposure, especially if the patient is having house dust mite associated triggers or allergic rhinitis, these patients can be exposed to immunotherapy, that is either sublingual or subcutaneous immunotherapy, which is available in Sri Lanka, and we have referred a couple of patients. This is again at the level of step 5. If the patient is having poorly controlled asthma, if the patient is reaching the level of step 5, you have to find out whether the patient is having features of type 2 inflammation. The supportive features are blood eosinophils more than 150, pheno more than 20, that is where pheno comes into action, sputum eosinophil levels more than 2%, asthma is clinically allergen driven, or the main requirement of very high dose or a corticosteroids. In these conditions, if biologic treatment is available, if the patient is getting suitable, or if the patient is suitable to start on biologics, you can try biologics, and based on the criteria which is shown on your right hand side, that is the blood eosinophil levels, whether it is childhood or adult onset asthma, or whether there are any other features like nasal polyposis. So based on these criteria, different biologics can be tried, and if the patient is having these criteria, their response to particular biologic will be high. Imagine patient is not suitable for all these things, not fulfilling the criteria, and on the other hand, biologic is not available. Again, you have to shift the patient to other side. Then you can try tiotropium or corticosteroids, azithromycin. Those things are available for the patients who don't have these options. Other important area that I would like to highlight is the changes that has taken place with regards to the management of acute exacerbation. Now, before discussing on the changes that has taken place with regards to management of exacerbation, we'll find out what is meant by exacerbation. So this is defined as exacerbation of asthma are episodes characterized by a progressive increase in symptoms of shortness of breath, cough, wheezing or chest tightness, and this is associated with progressive decrease in lung function. Recently, there are certain risk factors which has shown to get associated with higher risk of death. If the patient is having a history of near fatal asthma requiring intubation and ventilation, that is a advanced factor where the patient is having higher risk of death. And if the patient is getting hospitalization with asthma, if the patient is on or has been on steroids and recently stopped, that is again an adverse factor. If the patient is overusing SABA, as we discussed earlier, that is more than 1 canister per month without other drugs. If the patient is having history of psychiatric illness, because patient will not present at the first instance, and if the patient is having food allergy with asthma, so these patients are having higher risk of death. Again, this is highlighted. Increasing the as needed dose of ICS formoterol when asthma worsens reduces the risk of severe exacerbations requiring oral corticosteroids by 2/3 compared to SABA-only treatment. Again, combination seems to be superior when we compare SABA-only treatment. On the other hand, the combination is non-inferior for progression to severe exacerbations compared with daily ICS plus as needed SABA. So therefore, the recommendation is to start the patient on ICS formoterol combination. If the patient is having features of exacerbation, you can start the patient on short course of oral corticosteroids, that is about 5 to 7 days, which is equally effective to 14-day treatment. And the dose has been changed. The recommendation is to start the patient on 40 to 50 milligrams of prednisolone or equivalent dose rather than 30. The equivalent hydrocortisone dose is 200 milligrams per day, and it has been shown in several trials by increasing the steroid dose, the positive response will not be that much when you compare with the regular dose. Despite that, adding all these things, the other measure that you have to do is you have to increase the steroid component that the patient is taking. You have to increase the steroid component of the inhaler that the patient is taking. Imagine patient is taking ICS formoterol combination. You have to increase the ICS formoterol maintenance doses to increase the steroid component. And if the patient is on maintenance ICS with the SABA, then you have to quadruple the ICS dose to achieve a proper control. So we were not advising nebulization. For that, we are advising MDI plus spacer. So you can administer short-acting beta agonist by using a spacer and MDI up to 4 to 10 puffs every 20 minutes for about an hour, and you can assess the response. And if there is a positive response and if the patient is improving, you can reduce the frequency of applying the MDIs via spacer. It is mentioned 10 puffs of MDI is roughly equivalent to 5 milligrams of salbutamol via nebulization. So on the other hand, there is level A evidence to show delivery of SABA via MDI and a spacer or a DPI has a similar improvement in lung function as delivery via nebulizer. However, trials were not done for severe exacerbation. This is also a new recommendation where the oxygen targets has been changed. Patients should be titrated with regards to oxygen against a pulse oximetry, and you should maintain oxygen saturation at a level of 93 to 95, and you should not exceed the oxygen level more than 96%. Again, there is level A evidence in hospitalized asthma patients. Controlled or titrated oxygen therapy is associated with lower mortality and better outcomes than higher concentration with regards to oxygen therapy. Antibiotics, as you all know now, we have the tendency to start the antibiotics whenever the patient comes with an exacerbation. So most of these patients are not having infective exacerbation. So routine use of antibiotics in the treatment of acute asthma exacerbation is not recommended. However, if there is strong evidence, you can start the patient on your guideline. Routine arterial blood gas are not needed. However, if the patient is having very poor lung function, that is FE1 less than 50%, or for the patients who are not responding to initial treatment, or the patients deteriorate, then you have to do ABG and see the response. Again, routine chest X-rays are not indicated unless you are thinking of added cardiopulmonary diagnosis, or you are thinking of a pneumothorax where the patient is not responding for treatment. Ipratropium bromide can be added for your routine SABA, and this is associated with fever hospitalization and great improvement in peak expiratory flow rates and FP1 compared with SARB alone. So you can combine ipratropium bromide and salbutamol when you are providing acute care. Aminophylline and theophylline has been knocked off from the treatment, and it has been recommended not to use in the management of asthma exacerbation because of their poor efficacy and safety profile. And it has been shown in adult with severe asthma exacerbation, add-on treatment with aminophylline does not improve outcomes compared with SARB alone. You may experience this in your clinical setup also once the patients are deteriorating. Although you are starting the, although the patient has already been started on aminophylline, most of these patients need magnesium sulfate to control their symptoms. So the response will not be beneficial as we think, and the trial data is also against treatment. Routine sedatives are not recommended, and non-invasive ventilation has level D, weak evidence. However, you can try. Discharge criteria: if the patient is having post-treatment lung function more than 60% of the patient's best, you can consider discharging the patient provided the patient's risk factors are not there. Finally, I would like to touch upon on COPD asthma combination. Again, there is a change in the recommendation. Now, obstructive airway disease are of three types, that is mainly asthma, COPD, and on the other hand, there is asthma COPD combination. So if the patient is having asthma COPD combination, these patients has to be treated as asthma. So changes will be adhered to asthma COPD combination as well. Which means if someone is having asthma, we are not using LABA or LAMA alone without steroids. On the other hand, if the patient is having COPD, we should avoid high-dose inhaled corticosteroids, which is associated with increased risk of infective exacerbation, or oral corticosteroids. However, if the patient is having asthma, same thing applies. Finally, I would like to add this slide. Now, asthma is a disease, but you can spend a near normal life if your asthma is controlled. Look at these celebrities. This is David Beckham, the famous football player. This is Beethoven, the musician. This is Che Guevara, and this is Bill Clinton, former president. This is Jessica Alba, again an actress, and this is Charles Dickens, the famous writer. All these patients, all these people are asthmatics. However, they were able to win the world despite their disease. So, asthma is a disease which can control, and patients should be on a near normal life. In summary, asthma is a heterogeneous disease usually characterized by chronic airway inflammation, and the diagnosis is based on characteristic symptom pattern and variable airflow limitation. Continue prescribed medications, that is inhaled corticosteroids, during COVID pandemic. All adolescents and adults should receive ICS containing controlled treatment from the beginning. SABA alone is not recommended anymore. Thank you, and I would like to thank my supervisor, Dr. Saman Puratna, and my teacher when I was a registrar, Dr. Wickramasinghe, and all my teachers and my family who has supported up to this event of my career. Do you have any questions?
Some patients with asthma have a neutrophilic inflammation. Is there any phenotypic differentiation of these patients?
Yes, so that is now this type 2 inflammation is mainly associated with eosinophilic asthma. That is mainly these patients have increased sputum level, eosinophil levels, FeNO will be high, and they have more allergic associations if we are considering eosinophilic asthma. If these symptoms are not there, we are basically considering these patients are having more towards neutrophilic asthma, and the targeted phenotypic management and targeted allergic driven treatment will not be beneficial in those patients. Although there are certain measures that has been taken to identify whether with regards to the changes that has been associated with neutrophilic and eosinophilic asthma, it has been shown there is no significant changes that has been associated, although we are treating them separately. Only treatment differs.
When you start on the ICS,
yes.
Is there any evidence that prevents the asthma disease that has chemicals and sedation? In the long run,
yes,
that prevents the ultimate outcome and purpose of that.
That has not exactly shown, sir. Only evidence that we have is if we start the patient at ICS level, that is mainly the evidence is for metrol containing inhalers, the exacerbation risk and the death rate is less. On the other hand, it has been shown if the patient is started on inhaled corticosteroids at an early stage, the airway remodeling and the irreversible changes will be less likely rather than starting inhaled corticosteroids at a later stage. That is shown.
We generally would like to keep azithromycin as a reserve drug.
Yes.
Especially in our setting with incidence of tuberculosis. So what would you recommend for the local setup about using azithromycin?
What we can do is if the patient is having poorly controlled asthma despite your treatment, if you consider that the patient has to be started on azithromycin, you can do a sputum culture for AFP. And if you can exclude by culturing that the patient is not having non-tuberculous infection, then you can start the patient on azithromycin. You should not start azithromycin despite excluding atypical infection. That is recommended.
One question from me. In the stage 5 management, you mentioned something about
Bronchial thermoplasty, yes, bronchial thermoplasty is performed in other countries, although not available in Sri Lanka. So that is a procedure where the patient is subjected to a radio frequency signal by doing a bronchoscopy. So there will be certain changes in the smooth muscles of the airway. The evidence says by subjecting to this procedure, the short-term exacerbation risk will be high. However, if these patients are followed up for a long term, the exacerbations in the long term will be less. So initially there will be exacerbations, but after that their condition will be controlled, probably because of the changes that is taking place in the smooth muscles of the air.
You said now the theophylline has no place in the management.
Yes.
So do you think can we stop off theophylline from the national formulary?
Now this has become a huge problem because now almost, or if you take a prescription, if you take a clinic book, almost all these patients are on theophylline. How the evidence is now for the past 2 to 3 years now, even in the guidelines, aminophylines and theophylines are not included. So I think if there is no evidence, it is better to remove aminophylines and theophylline because we have other options to control asthma. In other countries they are measuring these aminophylline levels, so the risk of getting complications is also less. So we don't have monitoring facilities. Sometimes patient will be over treated with these drugs, so the chance of getting complications is also high, so better to avoid.
When we were over the treatment was to give it aminophylline highly injection, right, for injection, and there was absolute immediate response. If CDC aminophylline injection 1 milligram, and immediately patient response.
In fact, when I have told this to my supervisor, sir told the same thing. We were using aminophylines in our clinic setup, and patient had a dramatic response. However, the recent reports are against the treatment.
Any other questions, please?
That's a very good question. Now we have this question most of the time, but the recommendation is, if now especially this is important when the patients are having cardiac events, especially following an MI. In that case, you can go for cardioselective beta blockers, and cardioselective beta blockers can be started safely in asthmatics.
Okay, thank you, Dr. DSA, for that comprehensive talk. From the College of Physicians, can I present the certificate of appreciation for your presentation?